Okay, welcome back. We are here at CAT Lab number 4. Let me introduce the team. Dr. Carlos Fava on my right side, Juan, our fellow, Kevin, our technician, Mariana from our product specialist from Edwards, Alex here, our nurse, and Maria Eugenia and Dr. Cotto, Maria Eugenia, echocardiographer, and Dr. Cotto is our anesthesiologist today. Let me introduce the case first, and then we will show you what Dr. Fava has already done. Let's go with the slide. Okay, perfect. Move el arco un poco para que yo pueda ver las diapositivas, no para el otro lado. Okay, perfect. Next. So this is a 76-year-old male presented with the shortness of breath. He has history of hypertension, dyslipidemia, a PCI 10 years ago. He then received a surgical aortic valve replacement 7 years ago with a peak number 23. He suffered from endocarditis 1.5 years ago, and also he received a pacemaker implantation 2 or 3 years ago. In all these procedures who are done in another hospital. He is not fertile according to our team evaluation, and he is not fragile, of course. Next. So on the XCG is under pacemaker rhythm at 68 per minute. The blood test is quite normal. So the body mass index is 29. The echo Doppler showed left atrium dilatation with preserved left ventricular ejection fraction of 60 with some hypertrophic, and also a bioprosthetic aortic valve with severe dysfunction. He has a significant gradients, 60 and 30, with a Vmax of 4.2 meters per second, but also with severe aortic regurgitation, which in my opinion is the main issue in this valve. The pulmonary artery pressure is 50. The angiography showed the severe ostial artery, right artery stenosis. The STS score is 1.8 for mortality and 14.7 for morbid mortality. Next. So this is the angio. You see a normal left branch. The left main is okay. The LAD and the left circumflex are okay. The stent, which is in the proximal part of the LAD, is okay. No restenosis. Next. You can observe there dual chamber pacemaker. Next. And here you can observe a big right coronary artery with some calcification on the sinus and the sinotubular junction where the ostium is placed. And there was not too much reflux during the ejection. And also there was a damping on the blood pressure there. So that's why they did 2 or 3 different projections, and the ostial lesion finally was severe ostial lesion finally was diagnosed. Next. So there in this cranial angulation is better observed this very small ostium of this right coronary artery. And here on the angiography, we can observe a severe aortic regurgitation on this valve, probably a damage because of this previous endocarditis. Next. According to the app, in this valve, we can use a balloon or self-expandable valve. We have chosen a balloon. The recommendation is 23. For cracking, if you decided to use to do cracking, the recommendation of the app is 24. Probably we are not going to use 24. We are going to predilate with 22. So we have discussed before because it's a patient with the severe regurgitation. So probably we will not tolerate too much, and there is calcium on the sinotubular junction, and we had to place a stent on the right coronary ostium. Next. So this is the CT scan, probably not an excellent quality, but the diameter are in coincidence with the app estimation. The inner diameter of the valve is 21. Here we have measured 21 and 20. So the true ID is 21. The right, the ostium's heights are for the right 17 and for the left 18. So it does not, or it doesn't seems to be a big problem about the coronary ostium. The aortic angulation is 40. There's not the severe angulation also. Next. So this is the annulus that I mentioned once again, and the ostium and the aortic angulation. Next, and you observe there, excuse me, but here you can observe too, the calcification at the level of the above the right coronary sinus. Next. Here is the right coronary ostium height and the left coronary height. So both are above the post of the valve. It's very easily observed here. Where is the height of the valve and where the ostiums are. So I expect not having any problems regarding this. Next. Anyway, we estimate here the distance and also the VTC, which I already mentioned is 5.6. But remember, this is only an estimation because the valve is below the ostium, so this measure is not exactly true. And the distance from from the right ostium to the surgical heart valve is 5 millimeters, and the left ostium to the surgical heart valve is 8 millimeters. So we have enough space for the deployment of the valve without compromising the ostium, I expect. Next. So this is the angulation where we should work according to this CT scan evaluation. On the right view at 20 degrees with a caudal angulation of 12. But anyway, we have to check it with the ring of the valve to put a coaxial. Next. So this is the right iliac artery, which is a good artery, big, without significant calcification. This is our axis. Next. This is the left, which is also, again, a normal artery. Next. And this is the aortic configuration. There is not significant angulations, neither on the iliac nor on the aortic arc. So I don't expect any problem regarding that. Next. So in summary, it's a 76-year-old male with severe aortic bioprosthetic dysfunction. So after the heart team discussion with surgeons and cardiologists and so on, we have decided to treat in the same procedure, something that we usually don't do, PCI to the right coronary ostium and TAVI implantation for this bioprosthetic failure. Next. So this is our strategy. We are going to do right PCI on the ostium. We have used the femoral axis, the right. And then we have chosen for this case balloon expandable valve I mean, the reason was, and probably I know that you can argue on that, to have a good access to the coronary ostium in a patient with coronary artery disease, with osteal disease. He's young, so probably we might have some problem with the coronary access in the near future, especially if we had to do valve in valve or TAVI in TAVI inside the SAVR in the future for this patient. Next. So according to the recommendation, we have chosen, click on the PowerPoint, please, the 23 valve with 0 ZC is going to be an oversizing of 22, which is a little bit too much. But we plan to crack a little bit the valve with the 22 balloon before. Remember, the app recommended 24, so we are going to use 22. And then we will implant the S3 2023. Probably nominal or nominal. Okay, that's okay. Next. Okay, let's move back to here. Dr. Fava has prepared a radial access here, a 6 French, which is here. You might see here on the left arm, we have a contralateral access for protection and to introduce the pigtail for orthography and for control. And we have a 6 French that we have already done under echo and angio evaluation. Dame otra guía J que esta se dañó. Okay, so now it's okay. Okay. Probably Maria Eugenia, you can would you like to comment your echo find? Tenemos micrófono para María Eugenia. Let's see. Give me a second. So we are going to introduce one ProGlide. I think we can use one ProGlide and one angiosyl in this case, if you agree, Carlos.
I agree.
Okay.
Definitely.
This is the normal artery, so I think we are not expecting problems here.
No?
Sorry, wait a second, Maria Eugenia. Could you show the echo, please? So it's on the right side of the panel. Yeah, now you're on live. Hold. Déjala guía. Great. So now we have introduced the sheath for homolateral access. Another comment, please. He doesn't have any pericardial effusion. Is that correct? Okay, perfect. Pulmonary artery pressure. Okay. So do you believe it's predominant aortic regurgitation or stenosis? So you agree with me? Perfect. So now we are going to introduce the, wait a minute, Carlos. Let's go with the guiding, the right coronary artery guiding. So we are going to use an extra support wire to have a better support. My intention is to pre-dilate the ostium, to leave the wire in place. And then after deployment of the transcatheter valve, I would implant the right coronary artery stent. So probably Dr. Andres, who is again our digital moderator, could have some question from the audience, some comment. Probably my doubt were to use or to implant the stent before or after the valve test. Is the coronary. Okay. Probably it's not going to be too easy to engage. Test, Carlos. So here, please give me the wire so I can manage the depth of the catheter. Dame la extra support. So I can prevent to be la BMW extra support.
No?
So we are going to use BMW extra support. Just not to lose the position, especially when we are advancing or retrieving the delivery catheter. I don't like too much this guiding you have prepared. I don't want to mention the name, because if we have to use a guide extension, we might have problems. Wait. Let me go distally. Test. Please the pin to rotate. So I try to go as distal as I can. to have a better support. So Dr. Andres is managing the question from the audience. The patient is under conscious sedation. Yes. Oh, probably I made a big curve, too much big, too big. Yes. This is the problem of this wire. It's not rotating too much. Yes, please. Okay, now it's okay. I think I am distally enough here. Okay. So now that I have the wire there, I can do a better answer from outside to have a better vision of the osteum. As you can observe, there is a significant calcification on the aortic wall. So my intention was to pre-dilate with a cutting balloon. So probably I will try to cross the valve before. Then we pre-dilate the right coronary artery. We can check the positioning for deployment of the valve just in case we have to rush. And then we will try, do you have the coronary stent? We use 3.0, no, it should be longer, 20. Mm-hmm. 3.520. You should,
15.
no, try bring another stent. 15 is too short. Or 18. 18? Give me the pigtail. Let's move. Okay. A cutting, which size do you have? I think 15 would be okay because we don't have to protrude into the aorta. It should be exactly in the osteum. 15 is okay. The other issue is please bring me o traete o tenete a telescope. Cutting 2.5. So let me cross the valve. It's not that easy when it's a prosthetic surgical valve. Anda la vista AP.
Aquí, la.
Let me try like this. If not, we can use amplat catheter. Sí, agarra un amplat. No, it's okay, it's okay, it's okay. Oblicua derecha.
Es el Catherine.
Okay. We have extra systoles. We have, no, wait a minute. Let me position in the pigtail a little bit better. On the apex. Okay. So the ventricle is huge. So we can introduce the other pigtail. We can measure the gradient. We can do the angiography.
Dame.
Usually, when we have a significant coronary artery disease, we rather like to do on a stage procedure. But this is a very special case because we had to take care of the osteums. So I thought it was better to use this technique to do all together. Voy a necesitar una llave de I, una llave I. So we only have one injector. I have it. Ya está. Sorry about that. So let me see here. Sí. Pone un poquito caudal. Soltame la camilla. Ahí. Perfect. So I think this is a very nice view, Movete un poquito caudal. There. So I think this is the right position for working. There, the final one. Let's do another check here. Inject. Perfect. We have a very orthogonal view of the surgical ring of the valve. So we should go first to the to pre-dilate the right with the cutting. Okay, do you have the telescope? Okay, I would like to have it. Wait a minute. I will put the telescope shut to keep the catheter stable on the ostium to protect the position. Give me a second. I will introduce an extra bend to the wire to facilitate the crossing with the valve. Okay, so the key. Okay. Okay. So let's see if we can go with the telescope here. Vamos a la oblicuo izquierda que estábamos. So we can pre-dilate the ostium, and then we can advance the stent. And when the stent is in, we can. No, give me the llave de 3 vías. Aquí tengo. Oh, how much time do you have? Okay.
We have time.
Okay. I think it's a little bit unusual case. So we'll connect the injector here on the. Give me this. Okay, this is a cutting 2.5. So we will try to pre-dilate the ostium with this. If we have a good dilatation, it's gonna be okay. Probably somebody could ask me if I'm going to use IVUS. To be honest, it's gonna be too complex procedure for IVUS, although it could have been a good option. I will try to post dilate as much as I can. Aumenta la flora porque no se ve bien. Okay. This is an obese patient. Here we are, in the middle of the balloon, inflate. 1, 2, 3, 4, 5, 6, 7, 8, 10. So it looks too small, deflate. Tenés 3.0, cutting. So perfect. We are going to use 3.0. See. This 2.5 looks too small. Let me check. Okay, everything is okay. Let's go with it 3.0, and then I think we can deploy a 3.5 by 15, the stent. 3.5 por 15. Oh, be careful. Tiene fuerte. Okay. Okay, as you can see, the guiding not too stable there. Have to hold the guide and also the telescope. You might ask why I'm using the telescope. I will leave the telescope in the vessel while deployment of the valve. Let's go 10. Okay, now it seems better. Okay, deflate. Let me pull and push, trying to rotate the blades. So maybe we can have another ablation in a different place of this calcium. Let's go again.
10.
12, 14. Okay. 14 atmosphere is okay.
Bueno, Beto,
That okay. Stop.
por ahora.
Ancho, please. Okay, everything is okay. Give me some small amount of nitro because we have some spasm there. Okay, I will use probably 100 or 200 micrograms of, not too much because, you know.
No. Ah,
Okay, let's pull the balloon out.
ahí está. Vea.
Give me the 3.5 by 18.
Igual lo tiene metido en la coronaria derecha.
While this
Para
10 is there,
amplificación.
I'm gonna advance.
Ujú.
We haven't prepared for rapid pacing. We are going to do it with the wire. I have to put the big needle here.
Es una duda.
Here on the skin. The crocodile is there.
Yes.
Give me the black one. More things than usual for a TAVI case. But this is a very special case. Okay, give me the stand. You might turn the light a little bit. Poquitito la luz
Un penito.
de la microica, poquitito. Okay, there. Okay. Tené, Carlitos.
Sí.
Okay. I am introducing the stand. So the stent is going to be near the ostium of the catheter. Let me show the entrance of the stent to the telescope. Mostrame, pone de frente o así como estás. Okay. Let me see. Okay, it's inside. Perfect. You have to pay attention when you are entering to the guide extension, not to damage the catheter. And now the catheter is inside the guide extension near the ostium. I will advance everything together. So it's advancing okay. I will leave it here in the ostium just to prevent ischemia. Let me go with the wire. Okay. So have you prepared for high pressure inflation? The inflator, do you have another inflator and the syringe para inflar alta presión? Okay. You need another one. And una jeringa de 50. Venía la oblicua esa que teníamos de la válvula. Okay. Show me the distal end of the. Mostrame la punta del pigtail, distal end. Okay. I'm putting the wire there. Carlos is going to retrieve, leaving the wire in this position. So I'm going to ask Mariana if the valve is ready. Valve is ready. So we can proceed with the balloon, trying to pre-dilate or cracking or whatever. Okay. This is a non-compliant balloon. This is which balloon is Mariana? Atlas Gold or True Balloon? This is True Balloon. Okay. The only two non-compliant balloons that we have. excuse me. Do you have to connect the 50 cc here? Okay. So you are going to inflate first with the syringe. Then I'm going to rotate and you're going to inflate at 12 or, so, or something like this. Okay. This is a very bulky balloon. So show me the annulus, el anillo de la válvula, the annulus ring. Okay. Let me answer. Okay. No. Don't do anything without that. So here we are going. Scratch the wire. Give me a second for better
Conductors.
conductance. So here. Vení, Juan, aquí.
Yes.
I'm gonna hold the here. So, espera, no hagas nada. 180. Wait. Ahora, infla, fuerte, rápido. Rápido. Desinfla. Me para un poquito el marcapaso. Ok. Let's go again. Here. 180. Sí. Rápido. Ok. Now, Carlitos, inflate. Very fast, very fast. Give me a second. Okay, 10, 12. It's okay. Aspirate. Para el marcapaso. Okay. Now we have to recover the patient. Carlitos, pull this, everything out. Aspira, Juan. Will you give him some bolos? Coto. Dale un bolo. Mira más. Otro bolo plus. Balloon is broken. Mostrame abajo. Ok, arriba. Wait. Push the wire. Hacele otro centímetro, por favor, de adrenalina. Dámelo aquí. Dame adrenalina aquí. Dale, agarra la adrenalina, Juan. Vos agarra la válvula.
Dame la válvula.
Mostrame en
Una
oblicuo
válvula.
izquierda. So I'm going to introduce everything here. I'm going to go with the valve as soon as I can. I'm going to bolus of adrenaline. Should be ready. Mostrame que se vea la punta de la guía de frente
La punta de la guía.
y el introductor de frente. La punta de la guía y el introductor. Aquí. Déjalo. Tené, Carlitos, la guía un segundo.
Dale.
Ok. So, I'm gonna open. Empujame la guía. Mostrame el balón. Más abajo, más abajo. Ahí, ok. Teneme el introductor, por favor. Aquí. Empuja la guía. Okay. And now we have to hold it here.
No.
I have to introduce the
Me
balloon.
tiene que montar. Tiene que
Okay, we are
montar.
ready. Let's go. Vamos arriba. Anda a la procesión de trabajo de la válvula. Dale una adrenalina acá en el venoso, vos. Buena. Rotate. Por ahí vete. So here we are in the position. The patient is too hypotensive, it's not necessary. Pone más caudal. There.
Perfecto.
Yes. Sí. Now let me see. Okay, we are there. Carlos, let's go. Dale, Carlitos, dale. Vamos. Okay. Now the valve is working. Let me show in oblique izquierda. We'll put the stent. Dale otra adrenalina. Inyecta, Carlitos. Okay. Okay, inflate rápido. 10, 18. Okay.
18.
20. Desinflar. So,
Sí. Guarda eso.
okay, I think we have to compress. Vamos a sacar esto. The patient is. We have to hold the, vamos a marcapasear y we have masajear.
Hoy.
Sí.
Vamos.
Podemos ver el eco. Yeah. We have to compress.
80.
Okay.
80, sí.
Give me another adrenaline. So, delivery system is out. A 100. Ponelo a 100. So we have to work on that. Ostium is okay. Let me check. So it's okay, not unexpected situation. Okay. No pericardial effusion. So I think it's fibrillated. No? No. Compress, please. One. A very sick patient. You know. We have to keep doing that. RCP. A ver, déjame ver. I think the patient is now recovering.
Listo.
Okay. We are having a very tough situation. Be careful about the arrhythmias, so on. Now we are okay. Sorry about that.
Check the stem.
Let's check the stand. Okay, go. Now more pressure, please, there. Let's do 0 in the pressure. No, give me a nitro because no, el 0 is okay. Flash. So let's check the ostium first. Okay, let's go. Let's go, Carlos. So the ostium.
No, está con. Again, because it was water.
Okay, let's go again. Check. I don't have a good positioning with the guiding. Now I think it's better. Inject. Check, Carlos. So the stent is perfect. The patient is doing much better now. So I'm gonna pull the balloon. Just in case I have to post dilate, I will use a high pressure balloon. So you can show the hemodynamic. The patient now is little bit hypertensive.
Ventricular taquicardia also. Okay.
Let me do some nitro here in the coronary ostium. Okay.
Ahí está.
Okay, let me go to the coronaries. Nitro here. Test, Carlos. Okay. We wait some minutes. Give me some additional nitro. Give me the Amplats wire. I will pull the catheter out. Maria Eugenia, could you tell me how is the valve functioning, the gradient? The regurgitation doesn't seem too much because the systolic is, the diastolic pressure is 120. Have some hematoma here. So what we have to check here, if we have gradient, so if we need, excuse me.
Oh.
Wait a minute, she's
Yeah.
doing echo. Okay, and what about the gradient? If he's heavily, esto, he's still, well, oh, that's more than okay. Okay, we might wait some minutes to recover a more normal hemodynamics. Well, as this is the case, not that easy. We expect it, but probably not that complicated. So the valve is circular. There, now you can exchange the hemodynamic by echo, so you can share with the audience what Maria Eugenia is showing to us. You can show the gradient and then the regurgitation. This is nitro? No. Okay. Great. So let's do an angio now. 15 by 20, probably here. About the stand, we can inject there. Let's inject. Oh, sorry. I think the position is probably a little bit deeper than I would like to do it, but you know, I was in a rush. Not too much option. ¿Puedes sentar un poquito de caudal? Here. No, al revés, craneal. Here, okay. Here looks a little bit better. Inject. No regurgitation at all. So we have some hematoma here. You can compress from the other side. We are not going to post-dilate anymore. Please hold in there. And hold the introducer, Carlitos. So we are going to put the pigtail and measure the gradient. The osseal stent is perfect. And I think the valve is more than acceptable. So it's just to remind you that TAVI procedures always look quite simple, but you have this kind of procedures where you need a team working very fast because a complication can arise at every single minute. Now we will have to deal with this hematoma. We are going to use a closure device on the left side. So here you can share again, Rich, the hemodynamic. I think they are really beautiful. No grading at all. Diastolic is perfect. I think our outcome here is reached. So I can pull the catheter out from the ventricle. So let's see. Leave the wire in, Carlos. Déjala aquí. We are do a final test on the right coronary ostium. Disconnect this. Let me clean my hands. Let me check. Check, Carlos. Test. Ok, mostrame mejor el ostium ahora. Ok, okay. Inject. Dame un balón de 3.5 de alta presión. I'm going to post-dilate this ostium, although I did a atherectomy. It's still a little bit compressed according to the angiography. I would really like to post-dilate to prevent any restenosis. But as it was expected, the stent is above the valve, just in case we have restenosis or anything else in the future, we can go easily there. Teneme, Carlos, no me sueltes.
Entró.
Okay, that's it. Aunque no esté tan diluido ahora porque no se va a ver, sino. We will take care of the ostium. Let's go slowly, but to high pressure, to 20.
20.
22, 24.
24.
It's 3.5. Sí.
Yes.
28. Okay, that's okay. That's good. The guiding proximal. And let's do an ancho here.
Ponga campo coronario.
Pone campo coronario.
Campo coronario, pone. Okay.
Okay, inject. Well, the guiding is not perfectly engaged, but I don't like to produce any distortion of the stent with the guiding, which is prolapsing. Now I think it's much better. We have used 3.5, a very high pressure. We have had many problems, so I think we are done with this. So let me go out with the guiding. So give me a balloon, an 8mm balloon.
Balón de 8.
8 por 40. So we still have 10 minutes. We are going to close the access site before. We cannot revert the hibernization because the stent, so we have to get a good sealing. So I would like to check that the sealing is perfect. And then we are going to close with an ancho seal of the left side, and we will check it. Trae el arco ahora un poquito. Okay. Give me the introducer, Carlos. Remember that for pulling the device, I have to put the introducer to prevent any damage. Give me a little bit more light here. Más luz.
Cut. Cut the...
Sí, cortalo. Okay. Okay. The blood pressure is okay. Give me a second. Carlos is going to hold the groin while I cross over with the balloon, just in case. Got too many problems. I don't want to have any more. Going to contralateral is not that easy. It's N. Well, it's too bulky, this balloon. Okay. I don't know why it's not coming from here.
Date una verificación completa.
No. ¿Tenés de otra marca balón? Give me a different balloon. This is too bulky. ¿Eh? Sí, misma marca. Let's see. I don't know why. If not, give me the mammary catheter. Okay, now it's okay. Now it's okay. Okay. So Carlos is holding here. I'm gonna need a 6 French. Okay, holding here, Carlos. Yes. Please.
Dale.
Okay. Give me an 8 French angiosyl. Okay. Okay. So we have an acceptable ceiling here. But anyway, as we cannot revert the hyperinization, we are going to use an additional angiosyl. Holding calculators. So we are more than happy that we recovered the patient. It was a really tough case. Anyway, I can answer questions from the audience if they have it. I think I was right. Pre-dilating the right coronary artery before, because as you know, I expected some problems during cracking. So now, soltaron. Okay. So I think we're okay. We can revert la mitad de la heparina. I know that everybody probably were holding their breath like us. I'm really scared about the situation, but fortunately, I think we are doing okay. So let me check how is the ceiling on the groin. Carlos, let me see, abajo. Más abajo. So this, okay. The ceiling on the groin is perfect. So now we are holding because we have a oozing on the skin. We are going to check now here, the homolateral side. Pull the wire out and give me an unplugged wire. Rich, let me know how many minutes I still have. Rich, are you there?
You guys can stay a little bit longer if you'd like.
I think it's okay. 3-4 minutes is gonna be okay. No, I think probably on time. Let me check here. If we have bleeding outside the sheath, or what is going on here? Mostrame la ingle. Give me some contrast here. Okay. Oh, mostrame la otra.
No, otro.
Okay, there. If I have some problem here. Yeah, so we have there. So let's put a 8 French angioceal. And then we are going to compress, and probably we have exactly stick where this branch is. So we might have medial blood pressure from radial now. ¿Tenés, Carlitos? Okay. So this was the reason of why we have some bleeding there. After we finish, for sure, we might need a glass of water because it was really stressful. That's why. Okay. Give me the angioceal. It's here. Anyway, we are going to compress. No. Yeah. We have a problem. No, unfortunately, there was a kink in there. Probably this was the reason. And I destroyed the angioceal. So let me see if I can introduce the wire. Give me another 8 French angioceal. Well, give me the unplugged wire again, or the la guía regular. Okay. So this is the first time. Okay. Okay. There is a kink there. This was my problem. And this was the reason why. Mostrame arriba. Okay. I couldn't introduce completely. So now I'm gonna leave. So there's a problem with the angioceal. Comprime, Carlos, mucho.
Sí.
Give me this. Anyway, it's not gonna be enough, but it's gonna help. As you can observe, the hematoma is there, but we don't have bleeding. So this is good. Okay, corta. Okay, leave it there. So Dr. Fava is gonna hold with Juan the groins for probably 20 minutes to be sure that everything is okay. So we're exactly on time. We really passed a very tough situation, but fortunately we reached a very nice outcome, not only on the right coronary ostium, but also on the TAVI case, in this case for this valve in valve with the previous cracking. The patient collapses after the cracking, but there was no mechanical complication and everything is okay. So probably now we need a better medical management. Probably it's a patient with not enough preload. So we might check by echo if we need to expand him a little better because the blood pressure is okay, but the diastolic pressure Now it's not that high. So once again, I would like to say bye and see you next week. Thank you so much for helping us.